This lecture for CD 663 is a brief comparison of two methods of instrumental assessment that we have just gone over in this class, and that would be FEES versus MBS, or the flexible endoscopic evaluation of swallowing versus modified barium swallow. And I'm just going to briefly discuss when you would want to use these different types of assessment procedures. So let's begin with the kind of study that we're probably more familiar with. That would be the MBS. And I should say this comparison presupposes that you would have access to both of these technologies in your setting. Obviously, if you only have one, that's the one you're going to use. But many facilities have access to more than one, both of these, and maybe more. So this is a discussion of the relative benefits or merits of each of these kinds of procedures. First of all, modified barium swallow. For me, it's the default study. It's especially useful when I have no idea what's going on. That someone who has very little history that's available to me, that has vague symptoms, and I just need I suspect aspiration, but I need an overall picture of what's going on. And for that, I want an MBS. This would be also my choice if there was some suspicion about weird anatomical stuff submucosally. In other words, stuff that you couldn't see just from a surface inspection. So that would be abnormal osseous structures like cervical osteophytes, which are these little bony projections from the vertebra. Or if I wanted to see how recent surgery was possibly affecting someone's swallow, then an MBS would be what I would want to see, particularly if it was neck surgery of some kind. If I wanted to look at the oral stage, or base of the tongue movement, for example, then I'm going to need an MBS because you can't see what happens at the oral stage in a video swallow, in FEES, because all you get is the laryngeal vestibule. Now that's not anything to sneeze at, but it doesn't answer questions that you might have about the oral stage. If I had questions about the opening to the esophagus, the UES-PES, for example, if it was super constricted or hypertonic, meaning too much tonicity in the cricopharyngeus and other structures in the PES, then I probably am going to want to do an MBS to get a look at that stage. If I wanted to look at multiple structures at the actual moment or right before the swallow takes place, if I want an overall picture of what's happening in the oral cavity, near the epiglottis, right below the epiglottis, possibly even lower than that, then again, I'll need an MBS. There are three other circumstances, and you won't be the decider or the determiner of whether or not there should be an MBS for these particular cases, but it's nice to know what kinds of things would cause a physician to want a modified barium swallow. Globus complaints. So a globus complaint is that I have the sensation that there's something stuck in my throat. That is the globus sensation. And so it's fairly common for people to come in and just say, I feel like there's like a big lump in my throat and it never goes, it doesn't go away for a long time after I eat. There's no uniform anatomical explanation or physiological explanation for a globus sensation. People who have massive dysphagia often don't have any globus complaint, and people who have no dysphagia sometimes have globus complaints, like they feel as though something was stuck in their throat. So because it doesn't uniformly point to a particular etiology, and doesn't pinpoint even a part of the swallow that you're interested in, globus complaints often will elicit a request for an MBS. Any esophageal symptoms, automatically an MBS. And fistula after surgery, again, if you suspect that there may be some abnormal structural result after a surgery, like let's say someone has esophageal atresia or does not have a sturdy or even at all connection from the pharynx into the esophagus, and there's been a repair, but you're wondering if there's a little fistula or pocket that was left after the surgery, and that would explain perhaps why there's reflux or something like that. So, again, those last three on your chart there aren't going to be probably the things that trigger an MBS request by you, but they may very well be the basis of an MBS request by a physician. Okay, now let's look at the reasons why we might want to have a FEES evaluation of possible dysphagia. And these fall into two categories. There are no really good logistic reasons for having an MBS. It's expensive. It requires that the patient be transportable and is not obese. It requires that it's okay for them to be radiated. There's no good sort of logistic reason why you might want to have an MBS. The payoff, of course, is the film. But there are other reasons why you might then want FEES. For example, as I said, some facilities may not have an imaging department, like, for example, a skilled nursing facility, but they have a contract with a speech pathologist who has laryngoscopy available and can bring it with them. So for any patient for whom the journey is problematic, transportation to the hospital because they're sick, medically fragile, they're obese, they are recovering from a rather severe accident, and they are in a halo, for example, a structure designed to keep the neck and the head stable, or they're on a ventilator and they can't leave the ventilator. They're not safe to leave the ventilator even for a short time. Or they are quadriplegic, or they have muscle contractures, that is, so much tonicity in their limbs that they're permanently sort of contracted, and you see people who seem to be almost in a fetal position all the time. And those people are not going to be able to fit and sit in the chair that we typically use in an MBS. And of course, the whole radiation thing is a problem. Some people have already been irradiated a lot if they have had cancer or cancer surgery, and the physician and or you and or the family may not want them to have more exposure. There are also clinical reasons why you might want to have FEES. For example, you might want just to look at the surface anatomy. You might just want to look at a patient post-surgery for laryngeal cancer. They didn't have to take out that much tissue, but you would like to take a look at the tissue that's remained. Also, people who are VPI, so velopharyngeal incompetency, that's a term that is used for people who do not get good closure of the velopharyngeal port. And we typically think about that term as it relates to individuals who have, let's say, a cleft palate or a craniofacial anomaly, some kind of abnormality that prevents them from lifting the velum up and having it close off the nasal cavities. So those individuals then might be a good candidate for FEES, because it will show then the vocal folds, and possibly even as you're inserting the camera, you might be able to see other structures on the way. If you have patients who you have vocal fold mobility problems, so these would be individuals who have a paralyzed vocal fold, for example, and you're wondering just how much vocal airway protection they're getting. Fees is a very logical choice because then you don't have to irradiate them. You don't have to go looking through their whole system wondering, is their oral phase okay? Is their esophageal phase okay? If you know that they have a specific vocal fold problem, then fees makes a lot of sense that you can just take a look at the structure that you think is in trouble. If somebody has very, very severe dysphagia, and all you really want to know is the airway compromised? Is there material that's entering the airway? Then, again, these might be a logical, quick, non-irradiating kind of measure. It's going to show yes or no, is there aspiration? And if that is your question, then again, it makes a lot of sense. Patients for whom you have concerns about the airway, those patients too would be good candidates for fees. If you need any kind of extended look at the vocal folds. So let's say you wanted to do an examination, but while you're doing it, you want to see if you can teach them a technique that will tighten the opening to the laryngeal vestibule. So, and we'll cover these techniques soon, you teach them a technique that when they swallow, they need to push down on the top of a table pretty strongly, okay? Or you teach them they need to turn their head when they swallow, and you want to see if that maneuver, that exercise, can improve airway safety. If so, then it is a way for you to check. It's also a way for the patient to essentially get biofeedback about whether or not they're protecting the airway sufficiently, because they too can see the screen and figure out if that maneuver is helping protect the airway or not. So it can be a therapeutic aid simply because you are able to keep the endoscope in place as long as the patient can tolerate it. So it's a useful technique for that reason.